So thank you all for joining us this afternoon. I'm Joe Helbley. I'm the Dean of the Thayer School of Engineering, and it's my pleasure and privilege to welcome you for this special edition of our weekly Jones Seminar Series. Now, in just a few moments, we'll hear from Brian Pogue, Professor of Engineering and Dean, or former Dean of Graduate Studies, Director of the MS PhD program here at Thayer, who is generally the person standing in front of the microphone to introduce the speaker and welcome you. Before we do that, I'd like to take a moment first to recognize and thank Barry MacLean, who has not yet made his way down from the boardroom. Barry, are you here? Okay. Well, I will slowly recognize Barry MacLean, who just stepped in the door. Please join me. In recognizing and thanking Mr. Barry MacLean, whose dedication to Thayer has made this particular moment possible. Barry, as many, perhaps all of you know, is in fact a Dartmouth and Thayer engineer by training and a creative problem solver at heart, something that is immediately apparent to those of us who visited him at his home or at his office. MacLean Fogg Corporation, the organization that he and two generations of predecessors have built so successfully in the Chicago area. Barry graduated from Dartmouth in 1960, majoring in engineering sciences, and from the Thayer School in 1961. And through the decades since, he served as a member of and a chair to Thayer's Board of Advisors and as a former member of Dartmouth's Board of Trustees. Upon graduating from Thayer, as I mentioned, he joined the MacLean Fogg Company, one of the world's leading automotive parts manufacturing company, and Barry was its CEO from 1972 until 2017, when he turned over the reins to another Dartmouth and Thayer graduate, his son, Duncan MacLean. Barry's family helped establish the MacLean Engineering Sciences Center right next door, named in recognition of the family and their incredible support of and generosity to Thayer. It has served as a hub for gathering the Dartmouth community for more than the past decade. Over the years, Barry's received multiple honors and awards for his incredible service to Dartmouth and Thayer. The MacLean family generously established the MacLean Professorship at Thayer in 1988 to further our commitment to recognizing outstanding teaching and interdisciplinary learning and to help recognize faculty whose teaching holds true to the highest standards of Thayer's educational mission and whose research and scholarship have contributed significantly to the advancement of interdisciplinary knowledge. And that is the reason we are gathered here today. So before I introduce the next holder of the MacLean Professorship, let me just ask that we once again thank Barry and the MacLean family for their incredible support. And now it is my great pleasure to introduce Professor Brian Pogue, who is only the second person to hold the MacLean Professorship. Brian is a true embodiment of the values and virtues associated with the MacLean Professorship. Professor Pogue has been a member of the Dartmouth faculty since 1996 and currently teaches at both Thayer and at Dartmouth's Geisel School of Medicine. His scholarship in the application of optics in medicine to medical imaging problems focuses on novel imaging systems for characterizing cancer and for tracking the impacts and benefits of therapy. As I said earlier, at Dartmouth, Brian has served as Dean of Graduate Studies from 2008 to 2012, and he's currently serving for the second time as the Director of the MS and PhD programs in Engineering Sciences, and in a program he led the establishment of the PhD program in Medical Physics. Brian has published more than, graduate students please pay attention to this, more than 300 peer-reviewed papers and more than 400 conference papers in the areas of optical signals and cancer therapy, surgery, medical oncology, and radiotherapy. He serves as editor-in-chief of the Journal of Biomedical Optics and is a fellow of the Optical Society of America and the American Institute of Medical and Biological Engineers. Brian is also the founder of a startup company, Dose Optics, helping to develop the world's first camera that can image radiotherapy dose delivery as it happens, providing a crucial tool that helps physicians make real-time decisions in cancer treatment. This $11 million initiative, supported in part by the National Institutes of Health and other external partners, is the collaboration of a dozen Thayer engineering faculty and nearly 24 Geisel faculty currently working on 42 separate clinical trials. To date, this work and the work of Brian's laboratory has resulted in 13 company collaborations and also 5 startup companies. In addition, Brian's been a valued colleague and a respected member of the faculty throughout my 13-year tenure as dean. And so it pleases me greatly to be able to introduce him as the second MacLean Professor of Engineering for his inaugural lecture this afternoon, Imaging Medicine at Dartmouth. Please join me in congratulating Brian and welcoming him to the front of the room.
Thank you. I'm astounded at the turnout here. I really appreciate everybody coming over, especially those from the med school and other places. It's really a treat to have you here at the engineering school. Can you hear me okay up there? Yeah. A little bit louder. So I've been introducing speakers here for 12 years, and so now it's fun to be able to give this talk. I think this marks my transition to the old guard now here at Thayer. Officially, I'm going to become an old dude here. No, but I really appreciate it. I appreciate the honor of being named MacLean Professor, and am very excited about that. So in thinking about this talk, I wanted to say several different things. And so I decided to give a 4-part talk, sort of like a symphony. It's going to be 4 seemingly unrelated things that I'm going to try to weave together and convince you that they're related. It's going to start out with explaining what I mean by imaging medicine, and then give you some vignettes of the team science that's happened, and that's the exciting stuff. And then it's going to get a little risky and dangerous and talk about the risks that I see in this field. And then it's going to end on a very happy note, talking about engineering a solution, and that's the best part. So you have to stay awake. And if you sleep, I'm going to wake you up. And I do appreciate that all the PhD students are here because you think I'm going to fail you in 195. And that may be true, but I still appreciate that you're here. And I do need to disclose I'm founder and co-founder and president of Dose Optics, and I will be speaking about that today. So when I thought about this talk, and actually this is the name of the center that we work in at the hospital, the Imaging Medicine Center, I wanted to explain what that context means. Because when you think about medical imaging is viewed as diagnostic imaging, internal views using radiation, and it's largely relegated to a radiology department. That's the classic medical imaging. When you think about medicine, you think about active use of drugs, medication, promoting health, therapies, cures, palliation, relief, and they're in a large number of departments like surgery and cardiology. And so this is really the paradigm. Medical imaging kind of implies a single snapshot view, whereas imaging medicine is the concept of point of care or guidance, where you're actively imaging or providing imaging tools to physicians who need them. And that's really the gist of what we're trying to do at the Center for Imaging Medicine, is point of care. And again, point of care is this concept that the physician and the patient are in the same room together, and there's imaging happening that is helping the patient. And so these are just a laundry list of optical devices that are used at point of care, and many of us have had these devices used on us. And this is, and I'll explain some more about the rationale for how we want to develop some of these. And again, just to give it a little more context, if you think about how many physicians are in the United States today? There's roughly 1 million physicians in the United States. That's from the American Medical Association. About 5% of them do medical imaging. 95% do medicine. And so it's that 95% of physicians that we could help by creating novel imaging tools or imaging medicine tools. And that's really, again, the thrust and the concept behind what we'd like to develop. And so as an engineer, I think a lot about what biological features could we detect. What could we detect to help physicians or biologists detect features of disease or medicine? There are structural features. So if you open a physiology textbook, it will say there are structural features in the body. There are metabolic features in the body. There are immunologic features. And there are genetic features. And this is the paradigm I like to think about because of this, that there's a very steep concentration gradient as you go from structural features to genetic features. And so as an imaging person, it's actually quite obvious that we're not going to be able to image DNA because it's at picomolar type concentrations. Now, actually, if you invent one, that's actually probably a great Nobel Prize. Lots of people can sense DNA or amplify it, but of course nobody can image it because the concentration is too low. At the other end, structural things are really easy. So 99% of what we do in medical imaging, is image structural things. We image epithelium, connective tissue, muscles, organs, bones. And it's really the in-between stuff that is really the fodder of developing new imaging technologies. Metabolic features of tissue exist at the micromolar range. Immunology exists at the nanomolar range. And so as an engineer, as an imaging person, that actually gives you the target that you need to shoot for. You need the sensitivity level that's going to hit what you would like to image. And so it sets up this conundrum for imaging people that you'd like to go to the right for get better specificity, but of course it's much easier to detect things to the left. And so we largely image structures of the body, and we try to image metabolism or immunology. And as a physicist, and so those physicists or electrical engineers in the room will appreciate this graph. So this is the attenuation spectrum of water, and the body is basically a big bag of water. And so we go all the way from X-rays through ultraviolets, from optical to infrared to radio frequency and microwave. And to get radiation through the body, the attenuation has to be low enough. And so very obviously, we use X-rays because they have a low attenuation. We can get X-rays through the body. We use radio frequency in magnetic resonance imaging because, again, the attenuation is low enough that we can get that through the body. And then there's this optical window, and this is the window I work in, which is reasonably low. It has this scatter component, which is a little tricky, but again, we use optics to image the body. We don't use ultraviolet. We don't use infrared because those wavelengths just don't penetrate into the body. And so we use these wavelength bands to image the body with X-rays, optics, and microwave. And really, in the electromagnetic spectrum, there's really not many other useful bands to use. And so I often use this with the students. If you think about what tricorder would be, it would be using 3 different wavelength bands. And so I do think that the ideal tricorder, if we could invent it, would actually tap into all 3 of these wavelength bands. But that's kind of goofy, so let me move on. But the key thing to note is those metabolism, that immunology we'd like to image, have electronic resonances that are in the optical wavelength band. So most of the biochemistry we would like to image is actually contained in the optical wavelength band. And X-rays and radio frequency are great carrier frequencies, but actually most of the information content we want is largely tapped in this optical wavelength band. So that's a motivator for a lot of what we do. And so, again, in our center and when all the work I've done for the last 22 years here at Dartmouth, we develop imaging physical systems, contrast mechanisms, devices. We develop software methodologies. And in the medical world, there are the needs that we're hoping to address. We develop, and if things work, then there are consensus and guideline documents, companies and marketing and reimbursements. These are the drivers in medicine. And so for good or bad, a lot of biomedical engineering is creating really cool technologies and trying to push them into the medical place. That's most of what academic bioengineering does. But most of what the companies do, or what the medical world does, is look for the needs and search for the engineering tools that will help, right? And both work, but both can be dysfunctional at the same time. In fact, company marketing, for example, can drive a lot of what's available in the medical world, which is not ideal. Really, what we need is this iterative development. We need intimate contact between the engineering world and the medical world, so you get rapid feedback and that you can develop new ideas. And most new ideas don't work, and so you can cycle through and try different things. And that's what we largely try to do, and I think do at the Center for Imaging Medicine. And so I've been very lucky to be here at Thayer. Thayer School of Engineering has collaborated with people at the Borwell Research Building for a long time through Jack Hoops and others, have collaborated with the Cancer Center for a very long time, and has now invested in, I would say, in a forward-looking way, credit to Joe, invested in physical space at the Center for Imaging Medicine where we can routinely meet and have this iterative feedback. And so let me give you one example, okay, one concrete example. So in breast cancer surgery, lumpectomy versus mastectomy was a big issue. Back in the early 2000s, there was a large clinical trial. It was published in the New England Journal of Medicine. And it said that basically, this is survival, and this is years of follow-up, and comparing mastectomy to lumpectomy, and basically said that if you took the whole breast off versus just doing a lumpectomy, the survival stats were the same. And so obviously the transition in breast surgery was to go to a smallest excised area possible because it was better for the patient, cosmesis was better, and there was no difference in outcome. But the caveat is that the margins of that resection have to be clear. If the margins are not clear, then the outcome isn't as good. So this change in practice was good, but it set up another challenge, and this is, I would call this an engineering challenge, which is to make sure that margins can be clear in surgery. And so here's, very crudely, here's a lumpectomy specimen, and the question is there cancer in the margin of that specimen? Right? And so we started an academic industrial partnership program. And this was with Wendy Wells and Rick Barth, so in pathology and surgery, Keith Paulsen and myself, Venkat Krishnaswamy, Chad Kanek, and a series of grad students, Ashley Lafney, Bo McClatchy, and now Ben and Sam, to take a new technology, and this was largely invented here, this idea that you can image at high spatial frequency. And so this is the concept, is that we put stripes of light onto the tissue. And we demodulate those stripes of light. And if you just image with broadband light, you see one type of tissue right here. And as you go to higher and higher spatial frequencies, you actually pick out scattering features of the tissue. It's actually a new way to selectively image collagen structures and epithelial structures of the tissue and sort of pull it out in a wide field imaging modality. And at the same time, we worked with PerkinElmer to say, well, we should also do a micro-CT of the specimen because imaging the surface is fine, but we should also actually image inside the specimen. And so we have advanced this industrial academic partnership program to do both these things at the same time. And just to sort of bring it home a little more, here's a cancer, intralobular carcinoma, which is resected from a patient. And so the cancer is right here. And it's very hard to pick up, and on an X-ray it looks quite fuzzy and diffuse, but as you go to high spatial frequency, you see the features, again, those structural features kind of pop out. And this is, I love this example because it's so intuitive, but also non-intuitive, because if you change the way that you structure light, you see different things, and you inherently have a better dynamic range. And so now we can present the surgeon with a view of the tissue that looks like this, that kind of pops out those structural features of the tissue. Okay, right on time. So this is part 2. I have been a participant in team building and outreach, team science I would call it, and I do not take for granted the fact that I am in a place where incredibly smart students come. This school in Dartmouth is a magnet for smart people, and that's just a wonderful situation to be in. And this picture of Joe has nothing to do with anything. I just thought I'd throw it in there because it just looks charming. Yeah. So we have a very collaborative environment. We have a cluster called the Optics in Medicine. It's not, I don't call it my research group. It's just me and people who are willing to talk to me. And I think of it more like a commune or a cult type thing. We're embedded, in the Center for Imaging Medicine. And that's obviously within the Thayer School of Engineering. We're situated within the DHMC and Geisel situation. We're part of the Cancer Center. We're active participants in the Cancer Center, and I appreciate Steve Leach being here today, the head of the Cancer Center. We participate with Synergy. We have obviously external collaborators. I'm a big advocate of making sure that we're in a contact with the world. And we have professional societies and want to shape the dialogue, the national dialogue in medicine. And so this is a massive spider web of activity that goes on, and I focus mostly on optics. And again, I have been so lucky to have, lots and lots of Dartmouth undergrads work with me. Half of them are now medical doctors. The other half are running companies and engineering companies. And I'm kind of afraid they're going to be my doctor within a few years, but that's okay. They're smart people, so it's good. And then lots of PhD students I've worked with who are now professors, medical doctors, running their own companies. It's really been a real treat. And so Dartmouth Alumni Affairs has this phrase they like to use, that this is base camp to the world. And I love that phrase. I think that's exactly what we do. People come here, and then they go off, and they create something much larger than what they see here. And so I counted, and I think I've worked with 150 students in my 22 years, which is about 8 students a year. That's crazy. And this is where they are now. And then geographically, we're a little more localized in blue states, I think, but spread all over the U.S. And I wound up coming here because of Keith Paulsen, and I was hired as a research faculty to work with Keith. I didn't know anything about grants, or I didn't even know what a faculty search was. Keith hired me to come and work on some research, and Jack Hoops supplied the lab space, and we were going to create a biomedical laser lab, and that's what we did. And of course, those guys didn't look like that. They looked like this back then. It was a while ago before color photography was invented. And I bumped into Hal Schwartz, who's here today, and he helped me use his laboratory and gave me some great advice on tumors and oxygen. I met up with Julie O'Hara, and we collaborated for many years together, and continued my work with Tayyaba Hassan at the Harvard Med School. And this is, again, my advice to young scientists is having a network of senior mentors is absolutely critical to help you build your career. So Keith introduced me to this idea of building a team, an engineering team, and doing team science. And so we built near-infrared tomography systems for breast cancer. And this was with a program grant and a network of grants that Keith built up. And I won't go too far into this, but we really engineered a lot of systems to do deep tissue optical tomography and came up with novel ways to spectroscopically interrogate breast tissue for breast cancer imaging. And so you can see we were using the MR scan as a template and coming up with hemoglobin, oxygen saturation, water, lipids, and scatter features of tissue and doing clinical trials. And Shudong Jiang has been a partner of mine. We've done this together for many years. And I would say that we became and have become the global leader in deep tissue spectroscopy because we developed that team and we amplified it by bringing in many people. And I can't even show how many students have worked on this. It's been a lot. We imaged over 600 women, invented probably 5 to 6 different systems, and 200 publications. So massive engineering effort. But along the way, Dartmouth, we gained a reputation at Dartmouth as being the world leader in deep tissue spectroscopy. So that was really exciting. And we built a whole bunch of systems, and I'm just going to whip through this pretty quickly, a whole bunch of systems to do tissue spectroscopy. This is actually probably a small set. The most interesting part, though, was the idea that we needed to get into molecular contrast agents. Because, again, molecular specificity is one of the key values of optics. And so about the same time in the medical world, there was a ramping up of molecular contrast agents. And again, I'm not a chemist, and we don't have a lot of strength in chemistry right now, but we were lucky to collaborate with people who were developing contrast agents. And very specifically, molecular contrast agents that go to cell surface receptors. And so this is a video from a colleague, Go van Dam from the Netherlands, who developed, with Phil Lowe, he developed a molecular contrast agent that goes to ovarian cancer, and it's uptaken through the folate receptor. So basically, it's just a folate-targeted folate molecule that targets the folate receptor and is fluorescent and allows a surgeon to see a fluorescence image of the, and this is ovarian cancer. So while the surgeon's doing their surgery, they can see a fluorescence image at the same time to help them get a molecular trace on the cancer. So this is, and really this group is the world leader in this in Groningen, Netherlands. But there is a boatload of papers and research on exogenous molecular contrast agents. In fact, it's actually a shame because I did a quick survey and there's like 10,000 papers published on molecular contrast agents. And there's maybe 200, 300 clinical papers, only 12 clinical trials, and only 4 companies, and most of those companies are pretty fledgling, actually. It's really a sad state of affairs to see all these molecules and just this tiny little dribble of clinical trial activity. And so it's largely monetary reasons. Clinical trials cost a lot. The paradigm did not exist. Biomedical device development is in a very risk-averse climate these days. Therapeutics are good. Diagnostics are not so good economically. And so we started another industry academic partnership program with largely Dave Roberts and now Eric Henderson, Jack Hoops, Kim Samko, Sally, Jason, a lot of people to develop our own molecular contrast agent. And so this was to the epidermal growth factor receptor. And so we partnered with a company. We said, they had the patent on it, and we said, we want to develop it with you. We're going to take it through development, do clinical trials, and test out whether this is a good contrast agent for surgery. And so this is one of the neurosurgical cases. It's an EGFR positive tumor. Dave Roberts, actually, it wasn't Dave. I think it was another surgeon doing the surgery. Here's their naked color view. Here's the fluorescence view. Here's the overlay. And so again, this is giving the surgeon molecular information about the tumor while they're resecting it. Along the way, we invented a series of cameras. We did toxicity studies. We're now in the middle of 3 phase 0 microdose studies. And again, it's providing a molecular pathology view to a surgeon who would not normally have that view. And really now, Dartmouth, we present this, at conferences all over the world, and we're the leader in microdose surgical trials of molecular contrast agents. And it's because we took this team approach, very broad approach to advancing this. And right now we have about 6 NIH grants, 3 in the planning stages, and this is about a $10 million a year operation of creating a new way to image tumors. And another quick vignette, I've been involved in a collaborative project on photodynamic therapy for a long time, and Shane Chapman, the director of dermatology, is here, and he's been a long-time collaborator. And this is the concept where you apply a drug to tissue and you give a light, and that light is a light-activated chemotherapy. And so this is a preclinical lesion, actinic keratosis, takes up the drug. When the light is applied, it basically kills the tissue, so it gets inflamed looking because it's killing the tissue, and then within a matter of weeks, it clears the lesion. It's a great way to kill tissue, and we have been actively involved in developing dosimetry devices for actually probably 2 decades, more than 2 decades now, measurement systems to measure the drug dose in these lesions. And we've even sold these devices to the companies that make the drugs. And actually, Alberto Ruiz and Ethan and some others are helping us sort of take the next step, which is, we're being eclipsed. I feel like a dinosaur when I show this kind of technology. We should be using the commercial technology because an iPhone cell phone is actually way more advanced than what we're doing here. And so we are shifting gears now and going to, I would say, ultra-low-cost imaging-based dosimetry systems where we can actually image the drug uptake in the lesion just with a cell phone. And this is a very powerful technology. This is from a colleague of mine, Merrill Beal from Minnesota. He treats head and neck lesions, and this is a guy who had a head and neck lesion here. 10 years later, it's completely cured, and the cosmetic and the function, the elasticity of the tissue is very good. So even though this isn't really an imaging study, I've worked on it most of my career, and therapy is an important thing to advance as well as imaging. And so it brings me to my last little vignette. And so this is an engineering push example. So I was at it's sort of an anecdote. I was at a Royal Society meeting in London, and I met this guy, Simon Cherry, and he was imaging mice with optics, injecting them with isotopes and imaging them with a sensitive camera. And the light that comes off is called Cherenkov light. And so Cherenkov light is emitted from radiation. And so this is a pool of used nuclear fuel bundles, and you see the blue glow. That blue glow is Cherenkov light that comes off of the nuclear fuel. It's also produced from any high-energy material, so you see it from cosmic rays, and it's also the source of the blue flame that Godzilla sprays out of its mouth. So it's a radiation-induced optical phenomenon. And when I met Simon, he was sort of playing with mice, and I thought, that's really not interesting, but that actually could have tremendous implications in radiation therapy. And so just to educate everybody, radiation therapy is given to cancer patients. There's a linear accelerator, which is a beam of electrons that is accelerated to high speed, goes through a targeting device, and then is used to launch high-energy radiation through the patient. And so radiotherapy is now given to more than 50% of cancer patients, and so it's a high-volume activity. The beam is shaped, and as the patient lies on the bed, a very sophisticated treatment planning system has designed a shaped beam that goes into the patient's tissue, and the gantry arcs around. A very complex, in most cases, a fairly complex treatment plan is delivered. The quirky bit about radiation therapy is it is invisible. The patient sits on the table. They have no feeling of the beam going through them. The people delivering it cannot see the radiation. And it's all done by computer simulation and by various X-ray detectors, but nobody can actually see what's happening. And so that's where we got the idea that we could use Cherenkov light to visualize this. And so I partnered up with Scott Davis, Johan, who was a postdoc, and David Gladstone, the head of medical physics, who's here. And we showed that we could image radiation beams from linear accelerators. And 2 grad students, Rongjiao Zhang and Adam Glazier, helped out, and they really attacked this problem and showed that we could not just image radiation beams, but we could denoise the images and create really sophisticated images of radiation beams. And so we built different devices. This is a rotating water tank just to so that it would allow us to show that we could do really high-resolution imaging of radiation beams in water tanks. We did Monte Carlo simulations, predicting the radiation fluence going through tissue and through water. We got more sophisticated about imaging and cleaning up the beam so that we could, as the gantry rotates around a water tank, that we could do dynamic beam imaging. And more interestingly, that we could see the beam on a tissue phantom or on a tissue in real time. And so we could record movies of the radiation beam as it hits tissue. And these guys were phenomenal. In 4 years, they published 20 papers in their PhDs, so they were really amazing to work with. And I would say the key innovation that we discovered back in 2012 was that we could use an image-intensified camera, and by designing it appropriately, we time gate to the Cherenkov pulses, so their linear accelerator spits out radiation that's pulsed, right? And so we time gate to those pulses, and those electrical engineers in the world will recognize that's a very powerful way if you can lock into those pulses. We amplify, we do salt noise removal, we do background removal, and we can take an image that basically looks like gibberish and clean it up and get a very nice image. And really that's the secret sauce that we developed way back in 2012, is this ability to take a super noisy, low contrast image and create a very nice image out of it. And so along the way, what we developed was a methodology to do single photon imaging with the room lights on. And again, that may not mean much to you, but if you're an optics person, the idea of imaging single photons with the room lights on is insane. I would never say that's possible, but it actually is possible with the right sort of timing sequence and electronics. And so really it was Leslie Jarvis who was the next phase of this, and we teamed up with her, and we said, let's do a clinical trial. And so we started recruiting the first patients, and we started with whole breast radiotherapy because it's a very broad beam, hits a amorphous tissue volume, and the value was quite clear that we could see the radiation beam as it hits the tissue. And so this is the very first patient we imaged. Camera's on a tripod. Radiation beam is going across her chest wall, and this is the video that came out. And this is the first video ever in history of radiation hitting human tissue, which is pretty striking. Every time I present this, it's pretty amazing to me that this was done here at Dartmouth. First time ever to image radiation hitting tissue. We use X-rays all the time to image through tissue. We measure a transmission, but this is dose deposition in tissue. So this was pretty exciting for us. We really published this paper and moved on. And so we did a larger trial, and here's some videos. These videos kind of choked my computer, but there's a bunch of videos of different women who got treated, and we were able to capture videos of each treatment. And from there, we got a little bit more crazy. And so this is my last little vignette. This is kind of crazy stuff, but we put sheets of light now through tissue. And we realized, actually, radiation is a beautiful way to put light into tissue and kind of sweep it around. And so we developed what we would call light sheet imaging through the body. And so this is a rat, and we were able to inject an oxygen sensor into the lymph node and image through the full body thickness of a rat and predict the PO2 in that little tiny lymph node. And so we published this in Nature Biomedical Engineering just this year. And we've been exploring about how to push this into humans. And so here's a light sheet imaging across a human body phantom, and we're able to show that we could pick up things as small as a lymph node in a human body and sense the PO2 in those lymph nodes. So we're sort of taking baby steps in this. Again, this is a little more futuristic stuff, but this idea that you could use high-energy radiation sheets to biochemically sense inside the body. And the radiation dose can be contained to a fairly low value. And so things have, I'll just end here, things on this vignette, the things have really ballooned. We actually have expanded to a very large number of people now. As the group knows, we're doing a lot of different things, and looking at beam verification, total skin treatments, breast treatments, head and neck, targeted sensors, molecular tomography. So things have really expanded out, and luckily we've gotten funding to be able to advance in this direction. So that's been a lot of fun. So I'll end that there and say, the reason we're able to do this is because of this center. We have daily meetings with the people in the clinic, and we've created this network. And I hesitate to even show this because it sort of implies that there are people in the group and people not in the group. But it's actually kind of a spider. I think of it more of as a spider web of faculty. Some at Thayer, some at Geisel, some at both, and then lots outside as well. I think the most important thing is that we have 41 active human trials run by engineers. We have 18 patents, roughly. There's 5 startup companies, 13 industrial collaborations, and this all kind of operates on about $11 million a year budget of sponsored research. So it's been super exciting. And so that brings me to part 3. So you can wake up again. This is part 3. And this is opportunities and risks. And this is something that basically I have gained from my experience here, which is that team science works. Large funding exists. It's still based on engineering innovation. And most importantly, and I think this is probably the flip side of this is the most important thing, which is small research at the NIH is disappearing. Big research is growing, small research is disappearing. And so mentored and collaborative teams are the only way forward in the NIH-funded world. And just a little symptom of this, I made this plot for an editorial I wrote. Number of multi-PI grants at the NIH is going up and up and up. And so in physics and engineering now, over 25% of grants are multi-PI, and you can see the trend is pretty clear that it's going to continue. The good part, though, is that if you look at the funding for biomedical research at the NIH, this is the funding for physics and engineering. The number of grants has just been continuing to rise, and this is at a time where the number of grants has actually plateaued at the NIH. So this is actually quite striking if you look at this little graph here, and if you divide the two, this is it's a ratio, right? Number of funded grants as a percent, they're actually just in the last 3 years, there's been this jump in biomedical engineering funding to where now physics and engineering is about 1.5% of all the grants at the NIH. And I think this is largely due to biomedical engineering growth. So it's pretty exciting, and again, I conclude that there is ample funding for the type of research that goes on. And so the crisis, though, the risk, is this, and I'm involved in the publishing world now. Nature did a survey, and they said, do you believe the papers that we publish? And 90% said no. 90% said no, that there was a reproducibility crisis, that they didn't think that the papers they read in Nature were reproducible. And it's things like pressure to publish, low statistical power, not replicated enough in the lab, insufficient mentoring methods, poor experimental design, fraud. There's a laundry list of things. And, this is really, on the national scene, a big discussion. There are, how do we rescue biomedical research from its systemic flaws, misrepresentation and distortion of research in biomedical literature. This is a pretty big deal. And I think about this because, and I apologize for this crazy picture, I'm an editor of a journal now, and I get up every morning and I review 2 to 3 papers. That's my daily life now, is I review 2 to 3 papers every morning. So I think about this a lot, and but I host what I would call a community journal, Journal of Biomedical Optics, which is the oldest journal in our field. And so I think about things like making it the rigor better, enforcing data coding, sharing, focusing on translation. But really, it still begs the question of, why are scientific publications not reproducible? have agonized over this question for a long time. And I just discovered this paper, which I love, which is assessing the value of biomedical research. And they came up with what they said is the PQRST method. So P stands for productivity. So you publish, you get grants, you do things, so you're productive. Q is you measure the quality, which is the citation rate. You follow quality standards. R is you ask, was it repeated by others? In the scientific world, those of you know in the scientific world, if it's not repeated by other people, it means it's probably not repeatable. Then you ask, did they share their data and their resources? And then the last one is, did they translate it? Did they make it into something? Did startups, clinical trials? And so they propose this sort of sequence of analysis tools to measure the value of biomedical research. And I got to say, I really appreciate this, and I think that's what the measures that our center should be applying as we think about future research. And I wanted specifically to talk about translation, because I feel like that is the thing that engineers are the best at, is pushing things through to translation. And so this is the last section of my talk, so this is the most exciting part. You can wake up, which is engineering a solution. And so I'm going to continue on my Cherenkov bend here. So when we discovered and developed Cherenkov imaging, I wanted to translate it, but I actually had no idea how to translate something because I'm an academic and I don't know how to start a business. And so I actually rented a booth at a tech show, and they said, let's just do market research. And so I actually paid out of my own pocket. We rented a booth, and we just talked to scientists about this idea of Cherenkov imaging. And you can see David Gladstone here looking very happy with two of our grad students. And we called it Thayer Engineering. I just made the name up. Sorry, Joe.
I think it's taken.
Yeah. But we were basically just doing market research because we had no idea what to do. And so then I was very lucky. I met these guys. I met Bill Ware, who actually wanted to be involved in a company startup and had done a bunch of startups in Silicon Valley. Scott Davis, who's a professor here and also involved with Google Ventures. Venkat Krishnaswamy, Mike Germain, and Peter Bruja. And they completed what we eventually became as Dose Optics. And I got to say, when you work in a small company, which is what we've created, it is incredible when everybody at that company, and that's what this team is, are outstanding at what they do. We go to meetings, and I feel like every single person is actually perfect at what they're doing. Mike is a master at software. Peter's a master at hardware. Venkat is a taskmaster extraordinaire. Bill does everything that I don't want to do. And Scott, gives us advice on money and strategy. And so we were lucky. We applied for a grant, SBIR grant. We actually applied for 2. We got funded right away, which is unusual. We were lucky. And so that actually, if you've got money, everything is good. And so we went to Disneyland. Because what do you do with $1.5 million, right? You go to Disneyland. Actually, that was a conference, though. And so along the way, then, we've hired some great interns, Tin Shun, Victor, Emily, Will, David. And Victor was so good, we hired him twice. He boomeranged back to us, and it's been awesome. And so we set up in the Dartmouth Regional Tech Center. And here we are meeting and making cameras and being very happy. And Peter is our hardware master, so he creates the cameras. And here's the insides. And so, we went to more tech shows, did more market research. And this is, classic startup where we have a little bit of money and we're, trying to feel our way through to where is the market. And we've installed in Dartmouth Hitchcock Medical Center the first camera. And this was back in over a year ago. Well, April 2017. And so we started our first clinical trials with the official Dose Optics camera. And so now you can see the custom software that Mike has made, live Cherenkov view of a patient, cumulative Cherenkov view, and then we compare that to the treatment plan and the cumulative treatment plan. And so this is whole breast radiotherapy, and this is total body radiation therapy. These are patients with a lymphoma condition that have their entire body surface radiated. But this is the software interface. And so now it's a very functional tool. And this was the purpose of the company, is to take it from an embryonic project to a product that a radiation oncology department would be willing to buy and install in their institution. And so then we designed a better camera. We got more funding, got another grant, and then we just got word that we've got another grant. So now we're up to $5.5 million. And we did a product release earlier this year. We doubled the size of our booth at the tech show. See, everybody's happy, everybody's smiling. And it turned out that our patent got declined. So the entire company is based on this patent, and it got declined. And so Venkat and I had to fly to the Patent and Trademark Office and defend the patent. And this is Venkat before the meeting, and this is Venkat after the meeting. So that, obviously, getting that patent is a pretty big deal. But eventually we did get the patent, so it was worth going to the meeting. And this is a Dartmouth patent. We license it from Dartmouth. Dartmouth is a 4% equity holder in the company. So it's a great story. And so this is what I tell people. Look, you wouldn't have a surgeon who couldn't see what they were doing, right? Why would you have a radiation oncology team that couldn't see what they were doing? They should be able to see the treatment as it happens, and it should more than that, it should be electronically captured to verify the treatment as it happens. And that's what dose optics is about. We have installed in 3 centers. We have alpha test sites at 3 centers now, and we have 3 more in the planning stages: Harvard, Emory, and St. Louis. And we have installations at Duke, UPenn, and we have about 8 cameras at Dartmouth now. So it's an exciting time. Again, what we're trying to do as a company is push it into translation. And again, that's what I think engineers are very good at. Along the way, I was able, with John Weaver and David Gladstone, to create a medical physics graduate program. So we sort of able to give back to the Dartmouth community by creating a grad program. And these are some of the students at retreats, at the medical physics meeting. We went to a baseball game, and turns out the head of the medical physics world is actually a Thayer grad from 1982, I think it is. And he's the head of the Medical Physics Society. And so I'll just end. I'm going to wrap up now. The Center for Imaging Medicine, I've just described to you a couple vignettes, but there's really, I can't even count. I would estimate maybe 24 projects on the go. It's a network of collaborating researchers who work on different things to advance the ability to image medicine. And just to summarize, again, the drivers for me are thinking about what biology can we image, what radiology or what wavelength bands can we use to maximally probe those features, how do we embed what we want to do into the medical world, and then thinking about the fact that we need to be productive, we need to be impactful with our research. And so I love these metrics: productivity, quality, reproducibility, sharing, and translation. I think for me, that's the right roadmap for where we're going. Here's a list of alumni who I've worked with. Again, there's about 150 phenomenal people. I have to thank Kathy. I don't know if you're here, but Kathy keeps me sane by keeping me on track. And Tracy Ballou is amazing. So thank you very much for your help. My wife never comes to any talk. She's here today, so I want to thank you very much, Jane. She suffered through that. And I recognize this is the last Jones seminar that Joe will be dean, and I could not help putting in a picture of him today, before and after. And I hope I didn't contribute to that gray hair, but you can see pretty big difference from 2005 to 2018. A lot of gray hair happening. But Joe, thank you for everything you've done. Really appreciate it. And thank you especially to the MacLean Professorship Endowment for allowing me to be here and give this talk. Thank you. Not everybody wants. No. Yeah. Hi.
Question about the reproducibility statistic. Is that a new thing, or is that been the case for many, many years?
I think it's been around for a long time. Depending on who you ask, nature, I think, is the most predisposed to being having that situation because people publish their most ambitious and things in Nature. And so Nature Science, those very high-profile publications, that's where you're going to see things that may not be as reproducible as you'd like. And you hear this all over the place about drug trials, drug development in animals that just don't actually propagate into humans. This is normal, I would say, in the biomedical world. So it's a big problem, I think. And things like data sharing, in my world, reconstruction code, sharing your algorithms. People publish algorithms papers, but then they don't let other people see the algorithm, either make it a company and sell it or share it so that other people can verify it's true. It's a big problem. I mean, I tell my students all the time, we review papers, and I say, do you believe it? And most of the time, I don't believe what I read. That's just who I am. Yeah.
You talked about three very interesting techniques: Sarkov radiation, the contrast imaging, and then the spatial wave modulating the light.
Yes.
And so I wonder, is there a way to combine them or do something else to push to the picomolar regime, where maybe the combination of these three things will give you unprecedented sensitivity?
I hope all my students are listening, because that's what we should be working on is, pushing it to the absolute limit. For sure, sensitivity is a big deal. Optics can be very, very sensitive. The Achilles heel of optics is it tends to be superficial in tissue, right, surface weighted. And so that's why, the idea of putting radiation sheets through tissue, it's kind of like light sheet microscopy. If you know the microscopy world, it's revolutionized fluorescence microscopy for thick specimens. You put a light sheet sideways, and you image vertically, and you can sweep up and down and get really high volumetric imaging. I think what we're doing with light sheets with Cherenkov light and imaging allows us to image through whole animals. I'm pretty excited about that. We're working hard on it. We're trying to develop ways to do biochemical sensing in animals and hopefully be able to do that through several centimeters of human tissue. But yeah, you're right. I mean, combining those techniques could have value. We've played with the idea of spatially modulated Cherenkov. Yeah.
Brian, what are your plans for dose optics and commercialization? Do you ultimately, if these trials are successful, see the company as a manufacturer? Do you envision yourself licensing to someone else?
The CEO's right here, and I'm not sure he's going to let me answer that, but I'll say what I think. And
yeah. Talk later with the answer. Okay?
I mean, just quickly, we're a group of engineers, not marketing, right? So I think our core will always be engineering. Yeah. So that'll
technology development.
Tech development, and then productization, but definitely not marketing and sales.
One final question from the audience. Jack.
So Brian, of those things you mentioned, what is the greatest challenge? Is it the light penetration, the quenching, or just the small size of the targets that you're trying to do? If you had it, what do you think it is? I mean, it's going to limit it, or that you have to get it past.
For the
just getting a quantifiable image deep in the body.
Well, I think we can do that now with our Cherenkov light sheet imaging. Deep in the body's tough, though. Because the light still has to get out, we won't be able to image through more than maybe 3 centimeters of tissue. But 3 centimeters is a fair bit. So I think that we can do biochemical sensing for sure 2 centimeters into the human body. And will we advance that into human clinical trials? I think we will. But time will tell. I have to convince Leslie Jarvis to do
So do you feel
first.
like you're at the sort of limit of depth with the light wavelengths that you're using, or that anybody can use? Or?
Well, so so I've thought a lot about this. If you could push it out so that the signal coming out was in the radio frequency range, That would be fascinating. And there are probably magnetic particles or certain types of nanoparticles that could be used as molecular sensors. Put the radiation in as an energy in, get the radio frequency out, and do much, much deeper. So that's a good idea. We should do that.
So on that note, let me simply close by saying first, thank you again to Barry and the MacLean family for generously supporting this professorship. Thank you and congratulations to Brian for an outstanding lecture and outstanding piece of work. In my new role as provost, one of the things I've started asking people to think about, people I meet with in various parts of Dartmouth, is where is Dartmouth first? Where are we best? Where could we be the only ones doing something? First, best, or only? Where are we truly best in class? And Brian's shown us today, we are, his lab, his group, his community, is the first place where we have live imaging of radiation dosing medication. That is a tremendous accomplishment. And for that, I think we are extraordinarily proud to name you as the next holder of the MacLean Professorship. So please join me in, again, congratulating Brian, thanking Barry, and join us for a reception right outside in the Great Hall. Thank you.